we'll have our next speaker, Dr. Bipasha, talk on what do we do differently in oculoplasty. So as we are waiting, probably one question to Dr. Shubhra. You were talking about, non-surgically removing the lesions. I think for the larger benefit, we'd like to keep it for very simple lesions, right? Because you need to have a histopath in any case.
Yeah.
So
ma'am, in the European industry, because plasma has been in Europe for 10 years now, we have oculoplastic surgeons and ophthalmologists using it. They have experience, primitive experience. They have been using in oncology, but I haven't ventured into it because definitely we need an histopathology. But yes, it is only for benign lesions for now. But the world is doing it, so we don't know the future.
But just to make it clear so that people don't just...
And I think all these devices which I have shared, they are not the replacements for what we are doing. They're just the add-ons and the new tools in the kitty to make your practice even more elaborate and complete.
Yeah, I think probably for most of us, it'll be the first time to see all these things. So it's a good eye-opener for us to know what is in the armamentarium. Thank you.
Yeah, thanks. Good morning. Your heads must be reeling from the talks, but rest assured mine is very, very simple. And it's made simpler by Dr. Santosh and Dr. Kasturi. So I'm going to talk about two things: the management of vascular malformations and patient-specific implants. The vascular malformations of the orbit can be very confusing and complex. In fact, the International Society of Study of Vascular Anomalies have recently rechanged the classification of vascular anomalies, but these are not cut and dried. They're almost always combined malformations. This one is the commonest vascular anomaly that we see in children, but again, this present in varied formats. This is the same thing. Anyone? Capillary hemangioma of infancy. So in the past 10 years, we have been managing them with oral propranolol mostly, and the results have been pretty good. But in superficial lesions or premature babies, when you cannot use oral propranolol, to shorten the duration of treatment, you can also add a topical beta blocker. This is a pyogenic granuloma, also called lobular capillary hemangioma, and again, topical beta blockers like timolol works very well in these. So before chopping them off, you can try a 6 weeks course of topical timolol. This is a very complex venolymphatic malformation, or called lymphangioma. It can be orbital or systemic, and previously we were told not to touch them. The management was masterly inactivity. But nowadays, as Dr. Santosh already showed you, we are managing them quite well with intralesional sclerotherapy with bleomycin. This is a short video. And macrocystic lesions do very well. With one injection, they vanish. However, with microcystic lesions, you may need more than one injection. This is bleomycin mixed with lignocaine. And if it is retrobulbar, we do it under USG guidance. You can see on the right-hand side the needle, the injected inside the lesion. In superficial lesions, you don't even need USG guidance. You can directly go in and inject. Looks scary, but it is very, very safe because you know where exactly your needle is all the time. This is after one injection. This is a microcystic lesion, and this kid needed 6 injections before we could clear her visual axis. For these babies, we can try oral preparations instead of making them go through 6 general anesthetic procedures. Oral sildenafil is showing very good results, and also sirolimus or rapamycin. In fact, rapamycin can even be tried in topical format in other vascular malformations or venolymphatic malformation where the venous component is more than the lymphatic component. Venous malformations can be distensible or non-distensible. If it is distensible, it is called varix, and you may miss it if you don't tell your radiologist to make the patient do a Valsalva maneuver. Dr. Santosh already showed this percutaneous sclerotherapy with sodium tetradecyl sulfate, how to create the foam, and this is done under fluoroscopic guidance. Why? Because so we can see the flow of the sclerosing agent so that it doesn't go posteriorly. And this is just after the injection directly onto the skin. It does cause a little inflammation, so it is done under oral steroid cover, and this is the result. Sometimes if it is superficial, it can cause skin necrosis, which again looks bad, but the final result is very, very good because skin almost always recovers completely. This kid had a lesion from birth. It was progressively increasing in size. She was diagnosed as capillary hemangioma. She was treated with corticosteroids, propranolol, nothing worked. Then she came to us, and what you see is not a capillary hemangioma. This is a AVM, arteriovenous malformation. Please use your stethoscope, which you may have forgotten in your childhood cabinet, and put it on these lesions. You will hear a bruit. So AVM, you have to close the blood flow to the lesion. There's an arterial supply, there's a venous outflow, and in between the two, there's a nidus. How do you treat them? You first you do a digital subtraction angiography to see the feeder vessel and the veins, and then embolize the vessels. After embolization, you have to remove the nidus. If you don't do either of these two steps, you will be in trouble. So this is the digital subtraction angiography. You can see the nidus here, and this is the draining vessel. It doesn't have only one draining vessel. There are multiple draining vessels. This is maxillary, this is superficial temporal, and this is the percutaneous axis, and this is filling with the sclerosing agent. This is the glucust. This is the nidus. This vessel has not been occluded. So the interventional radiologist told us on table, expect some bleeding from this, but otherwise there is no bleeding from any other place. This is after the sclerotherapy where there is inflammation. This is just after surgery, and then unfortunately by the time patient presented to us, she had very dense amblyopia because of the ptosis. So she has isotropia. Not only AVM, even some tumors can have a very vascular entity and a feeder vessel. If you don't block this feeder vessel, again your surgery is going to be very, very messy. So again the management is embolization followed by excision. This is a hemangiopericytoma. You can see the glucust. This is the feeder vessel which has been blocked. So this is the summary of the management of vascular lesions as we know now. It is changing. There are a lot of studies going on, so we hope to see some improvement in the future. The second thing is the patient-specific implants, which I wanted to tell you about. So already we have talked about mirroring. The normal side is mirror onto the fractured side, and if you subtract that, you get the deficit on that side. The deficit is converted into a patient-specific implant. Why do we need a patient-specific implant? Because the normal implants that are readily available in the market may not cover complex or large fractures. So you get a post-op result like this. This is the fracture. This is the implant. So these patients need a patient-specific implant. See the fracture? There is nothing, no strut, posterior strut. The globe is almost in the maxillary sinus. This cannot be managed with a pre-contoured implant. This is the pre-contoured implant that is readily available, but this is the patient-specific implant which is larger and with the concavity of the and convexity of the inferior floor. And this is the post-operative result. You can see the patient-specific implant covering the whole of the fracture. Not only fractures, we can also do orbitofacial reconstruction with patient-specific implants. This is a hemifacial atrophy from childhood, and again mirrored the normal side onto the abnormal side, find out what is missing. He needed 3 implants. This is for the zygomatic arch and the ZMC. This is the mandible, and this is the glenoid fossa. This is made by PEEK, this is titanium mesh, and this is polyethylene. So there are different materials that you can use in patient-specific implants. And then it can be put under navigation guided, as Dr. Kasturi already showed you. So this is the pre-op, and this is the post-op result. You can see the improvement in the maxillary and the mandibular region. Still needs some correction here. So you have to customize your treatment for complex conditions when patients present to you. One size does not fit all. And the main thing in oculoplasty surgery nowadays is collaborate, collaborate, and collaborate. I'm very glad and proud to have a team of radiologists, interventional radiologists, and max-fac surgeons to treat our patients, and you should also build a team. Otherwise, these patients will not get optimum treatment. Thank you.
Thank you, Bipasha. I think that was yet another nice organized way of putting things and putting across the fact that we all have to work as a team. Thank you very much. Now we have the last speaker for the session, who's the actual owner of the session, Dr. Fairuz, who put it all together, and such an important and useful session it has been. Thanks to Fairuz for this. And she'll be talking about the principles and protocols in ocular oncology.
Good morning, everyone, and thank you very much, ma'am. So it's just not me, it's again a big team, as Dr. Bipasha said, for this exemplary session over here. I'm sure you have got an overview of the beauty, aesthetics, and many more in oculoplasty. So what I'm going to talk to you here is regarding a little bit more, life-changing topic, which is ocular oncology. Although being a very niche specialty, there are certain things that we have to keep in mind, and more challenging for an ocular oncologist and an oncologist currently is the rapidity in which the change is happening in the knowledge of the scientific basis of cancer oncology, and the steady fast changes in the therapeutics which is available, especially understanding the rapidity of understanding of the molecular basis of tumor cells and cancer processes. So this has in fact changed a lot in the management of ocular oncology, and as a treating specialist, it's very, very important to know the principles and protocols. So I'll go in a few stepwise manner. First of all, diagnosis. The clinical diagnosis compared to a lung cancer or a breast cancer or a GI cancer, for an ocular oncologist, it's a little bit more easier, because a conjunctival tumor or an eyelid tumor is much more obvious, and most of these tumors are of clinical diagnosis. As in this case, it's a lid tumor, which is very much obvious. Unlike other cancers in the body, it makes a little bit easier for us to identify the tumor, and sometimes the extent of invasion and the severity of the disease. So are the conjunctival tumors, where in fact, even with a very small clinical test, you can actually identify the invasion, although you need to know what you have to do with these patients. Now, so is in retinoblastoma. It's always been a clinical diagnosis, even intraocular tumors like melanoma, ciliary body medulloepithelioma, and many other benign tumors. Now, regarding the extent and behavior, yes, investigations are ancillary in ocular oncology, and it is essential in certain situations, even in a tumor which is very, very clinically visible over here, in order to assess the invasiveness of the tumor, which in fact changes the staging and the classification and also the prognosis in these patients. Well, orbit is something you have to have an ancillary investigation, be it a CT scan, a computerized tomography, or a magnetic resonance imaging. Now, the question is whether you do a CT scan or a magnetic resonance imaging, which both has equal, importance when you want to know the bony outline, because most of these malignancies would have bony changes as an erosion or an hypoplasia of the bone. So CT scan is definitely, the armamentarium to think of, an MRI in soft tissue detailing of the tumors. Well, as I told you, intraocular tumors are clinical diagnosis, but there are situations where you don't know what is happening to the optic nerve. Well, optic nerve can have optic nerve extension and intraocular extension. So yes, imaging plays a major role. So this was a patient with proptosis where you definitely don't have the visualization of the fundus. So imaging plays a major role, as an ultrasound B scan can also tell you whether there is an intraocular tumor, but MRI is so very important to know the severity, and this child has an intracranial extension. Now, going on to tissue biopsy, biopsy can be diagnostic and curative. So diagnostics are where you have a query differential diagnosis of these tumor, where you cannot the entire tumor is not amenable to excision, and then you take an incision biopsy. And therapeutic, when the tumor is very well defined and large, where you go and excise the entire tumor. Histopathology plays a very important role in ocular oncology, and of course without an ocular oncology pathologist, most of these tumors cannot be diagnosed or even treated. Again, pathology has also evolved over the past. It's just not getting the H&E staining or the basic ocular pathology, but confirmatory in most of the tumors nowadays is immunohistochemistry, which gives you the type, the grading, etc. of a particular tumor. And also the genetic markers that the histopathologist gives you also gives us an overview about the behavior and the prognosis of the tumor, as in this case of having sarcoma, where we have to do the FLI1 gene. Now, the staging of ophthalmic malignancy is very, very important for solid tumors. Most of the tumors are solid tumors in ocular oncology. So we actually follow the American Joint Committee of Cancer, the TNM staging, where the tumor extent is actually assigned in numerical values depending upon the severity of the tumor. This is a conjunctival melanoma, a small tumor to a big tumor, which is actually classified according to the AJCC TNM. And we have the 8th edition now, and this is applicable in most of the tumor. And depending, by summing up these numbers on tumors, nodes, and metastasis, we actually stage the disease. Now, staging of the disease, we do consider positron emission tomography in most of the malignancies in ocular oncology to evaluate the systemic involvement in these tumors. This was a patient who actually was referred as a case of photosis correction, came out to be a lymphoma, and in fact the subtle puffiness of the eye led to the glaring thing where the entire body was involved with lymph node metastasis. So PET scan is definitely something that you have to think of in systemic evaluation, and of course bone marrow and CSF cytology. Now, going on to the treatment planning, it involves a multidisciplinary team. It's just not the ocular oncologist. It involves a pediatric oncologist, a medical oncologist, a radiation oncologist, a geneticist, etc. So you need to have a team if you're doing an oncology practice. Just being a clinician doesn't really help you. So building a team around you is so very important. Now, depending the treatment planning, it depends upon the type and the extent, and there are various therapeutic regimens which is available, but evidence-based, and those, especially if you have a clinical trial which has proven to be useful for these tumors, has to be accepted as a treatment modality and just not random treatment. Individual factors, yes, in a country like India, a less developed country, well, the age, the socioeconomic background, and general health of the patient is very, very important. So it's so very important to follow a accurate, accepted standard treatment guideline, not only for the patient, yes, that is the primary focus. Apart from that, comparing results for research and publication, etc. is so very important. So going on to the surgical protocols, well, something that we always follow, be it eyelid or conjunctiva, is basically getting a tumor-free margin. So the margin clearance, be it a Mohs micrographic surgery or a frozen section, which is much more available in our clinical setup, is so very important. So our principle in surgery, which is a gold standard in most of the ocular tumors, is to get a margin where we actually do a wide margin excision, as in like this, and then the tumor is actually submitted to the histopathologist with orientation of the histopathology specimen to know whether the base or the margins are positive. So is in conjunctival tumors, where you actually take a wide margin of these tumors, be it cornea or conjunctiva, and even if there is scleral invasion, you do a partial lamellar sclerectomy. In orbit, the principle stays that if it is a completely resectable tumor, where it is even a benign which can go for a malignant transformation, it's always good to get the entire tumor out with the capsule, all right? But well, we can land up in situations where we have tumors which is kind of diffuse and it's not amenable for complete resection. Now, here also there are certain surgical principles that you have to follow. You can see this tumor over here. Well, it is heterogeneous, and in the center part of the large tumor is the necrotic tissue. So you might go inside and take just the necrosis, and you might land up not getting, appropriate histopathological diagnosis, or even being able to do an immunohistochemistry in this patient. So according to our principles, we actually go layer by layer, a superficial, deep, and the deepest tissues are taken in these patients and then evaluated. So regarding the therapeutics, we have chemotherapy. Chemotherapy can be induction, consolidation, maintenance, neoadjuvant, adjuvant, salvage. These are the various ways of use of chemotherapeutics. We have molecular targeted therapy here, understanding the molecular basis of most of these tumors, applicable for surface tumors, orbital tumors, and lid tumors, and yes, radiotherapy. Stereotactic, gamma knife, and this has the change and improvement in biotechnology has given us so many newer treatment modalities in radiotherapy as well. And well, of course, most of these tumors in our setup, where we find a lot of advanced tumors, requires actually a lot of combination of a multimodal treatment protocol. So, well, this is a patient where the patient had a sphenoid vein meningioma, presented during the COVID, and the patient could not spend a month in the hospital. So the newer advancement in radiotherapy led to 5 days of radiotherapy, delivering 25 gray of radiotherapy with a hypofractionated radiosurgery. Then comes the ultra low dose radiotherapy, where this patient has bilateral lymphoma in both the eye, and well, this is the advancement where a 200 centigrade plus 200 centigrade in 2 fractions in 2 days was given to this patient, and the patient is tumor free for the past 3 years. So to conclude,